Hi. So we started this 18-point series last week, and thank you for such an overwhelming response. So as a continuation part, we'll be making a series of videos based on the time availability, and in each video, as I mentioned in the previous video, we'll be having 18 important points which we'll be discussing in a brief and crisp manner, right? So coming to the 18 points in this video. The first one, why is surgical stent required for immediate denture? It's used in fabrication of immediate denture in order to give an idea of the regional anatomy so that it acts as a guide for recontouring tissues after extraction. So that's the purpose of a surgical stent. The least likely fracture site in mandible, it's coronoid process with a percentage incidence of 1.3%. So coronoid fractures account for 1.3% of total mandibular fractures, whereas the highest number of fractures are seen in case of condyle and angle, which account for around 24.5% of mandibular fractures, and symphyseal and parasymphyseal fractures account for 22%. Unspecified fractures account for 2.2%. Fracture of body of mandible accounts for around 16%, whereas fracture of alveolar process accounts for 3.1%, and fracture of ramus accounts for 1.7%. So the least is seen with respect to coronoid process, and the maximum number of fractures are seen in areas of condyle and angle, which account for 24.5% respectively, right? Next, a pulpectomy involves extirpating pulp in pulp chamber as well as in root canal, right? Next, in mandible, the greatest oppositional growth occurs along the posterior border of ramus of mandible. Next, thumb sucking can cause protruded maxillary incisors, lingually tipped mandibular anteriors, and anterior open bite, right? Next, how do you treat a vital permanent second molar with a 1.5 mm exposure on a 12-year-old patient? The age of the patient is 12 years, it's a vital tooth, it's a permanent second molar. It means usually second molars erupt at an age period of 11 to 13 years. It means the tooth is in a stage of young permanent. It means it's an young permanent tooth, YPT, with a wide open apex and blunderbuss canal side. So in such cases, whenever there is pulp exposure, and they mentioned in the question or in the point that the tooth is vital, then we go for apexogenesis. So we go for apexification when the tooth is non-vital. We go for apexogenesis when the tooth is vital, and these apexogenesis and apexification are done in cases of young permanent tooth. So young permanent tooth is nothing but a newly erupted tooth whose root apex is still open, it's not closed yet. So in case of permanent teeth, the root apex closes after 3 years, approximately after the eruption of a tooth. In case of deciduous or primary teeth, the root apex closes at around 1.5 years after the eruption of crown, right? So the young permanent tooth stays in case of primary teeth is 1.5 years. The young permanent tooth stays in permanent teeth is around 3 years. Hope it's clear, right? So in case of how do you treat a vital permanent second molar with 1.5 mm exposure on a 12-year-old patient, we go for apexogenesis in order to allow physiological development and root apex closure. Next, direct pulp capping is recommended for primary teeth with mechanical exposure. So carious exposure, we don't go for direct pulp capping, right? It's not indicated, whereas direct pulp capping in primary teeth is indicated only when there is mechanical exposure, right? So that the vitality of the exposed pulp and the remnant pulp is maintained. Next, a calcium hydroxide pulpotomy performed on a young permanent tooth, YPT, is successful. It's considered successful when the patient is asymptomatic, when the tooth responds normally to electric pulp testing, and most importantly, when the normal tooth development continues. That's what we discussed previously, right, in apexogenesis. Next, the periapical lesion that would most likely contain bacteria within the lesion is. So we have various periapical diagnoses, right? Periodontitis, apical periodontitis, we have this periapical granuloma, etc., right? So the question is, or the point is, the periapical lesion that would most likely contain bacteria within the lesion, it's abscess, it's periapical abscess, because acute periapical abscess is, histological studies have proved that they are polymicrobial. They contain obligate as well as facultative anaerobes. Various obligate anaerobes such as Prevital and Fusobacterial species are present in various facultative anaerobes such as streptococcal species of bacteria, they are present within this abscess, right? Next, with juvenile periodontitis, the teeth predominantly involved include first permanent molars and also the anteriors. That's very important. So in case of juvenile periodontitis, the teeth predominantly involved include first permanent molars and anterior teeth. And coming to few important points pertaining to this LJP, localized juvenile periodontitis, the age at which this LJP is commonly seen is circumpubertal, right? And systemic manifestations are rarely seen, or they are not seen in case of LJP. However, the characteristic clinical finding, intraoral finding, is bone loss is evident in incisor region and molar region, and it is symmetrical in fashion, right? And onset and course, it is insidious and rapid in onset. Gingiva, little clinical inflammation is seen, plaque is rarely seen or little amount of plaque is seen. Microbiology, characteristic gram-negative flora such as Actinobacillus, Actinomycetum comitans. These bacteria are commonly associated with this LJP. And other important findings include involvement of regional lymph nodes, familial pattern, and polymorphonucleosides, neutrophil dysfunction, and no involvement of primary teeth, right? So these are some of the important points pertaining to LJP. Next, the optimal amount of tooth reduction on a molar for a porcelain fused metal crown preparation is, so in case of PFM it's 1.5, in case of full metal it's around 0.5 to 1, right? And in case of all ceramic it's around 2 mm. To be more specific, if it's a metal crown, the occlusal reduction is 0.5 to 1 mm and the marginal preparation is 0.5 mm chamfer. In case of porcelain fused metal, the occlusal reduction is 1.5 to 2 mm. It depends upon whether it's a functional or non-functional cusp, and the marginal preparation includes 1.2 mm of labial shoulder or heavy chamfer, and lingually we place a chamfer, 0.5 mm of chamfer, right? In case of porcelain fused metal, labial shoulder and lingual or palatal chamfer. And in case of all ceramic, the occlusal reduction is approximately 1.5 to 2 mm and the marginal preparation is around 1.5 mm, which is a rounded shoulder, right? So these are some of the important points pertaining to tooth reduction in case of metal, porcelain fused metal, and all ceramic. And which local anesthetic, next point, which local anesthetic drug is least likely to cause an allergic reaction? See, we have amides and esters, right? As you all know, amides are comparatively safer and least allergic compared to esters, right? So lidocaine is considered to be the safest. I mean, it has the least potential to cause allergy. In local anesthetics, esters are more prone for allergic reactions comparatively because of the formation of para-aminobenzoic acid as an intermediate during the course of metabolism, and also main factor or main constituents that can be implicated for allergic potential include methylparaben, a preservative antifungal agent present in LA, and also we have this antioxidant metabisulfite, right? So these agents are commonly implicated in allergy, in causing allergy in various patients, if at all patient has allergy to local anesthesia, right? Hope it's clear. So as I mentioned, preservatives like methylparaben and antioxidants like metabisulfite, right? And coming to next point, when treating deep pockets in patient with juvenile periodontitis, so we discussed about LJP previously, right? Coming to treatment aspect, and when treating deep pockets in a patient with LJP, the least effective treatment is, so it's occlusal reduction. So first we'll briefly discuss the non-surgical and surgical modalities involved in treating localized juvenile periodontitis. In coming to non-surgical treatment options, we have the first priority is plaque control, root planing, antibacterial agents, orthodontic treatment, and least occlusal adjustment. And coming to surgical options, we have mucoperiosteal flap, osseous grafting, autologous tooth transplantation, hemisection, root amputation, and the least preferred option is extraction. So the non-surgical option which is least preferred for treating LJP is obviously occlusal adjustment, and in case of a surgical modality, the least preferred option is obviously extraction, right? Coming to the next point, materials that produce the best osseous graft regeneration are, they are autografts. They have different kinds of grafts, right? So autografts are considered as gold standard bone osseous materials because these bone grafting materials have property of osteoconduction, osteoinduction, and osteogenesis. Osteoconduction, we have this osteoconduction property. It's because this grafting material, autologous, acts as a scaffold. Osteoinduction, because of presence of bone morphogenic proteins and various other growth factors, and osteogenesis because of presence of various osteoprogenitor cells, right? So autograft, or this the so-called autograft, it's considered to be as a gold standard in bone grafting material, right? And the source of this autograft is anterior and posterior iliac crest of pelvis. That's very important. Next, what is the main reason to splint a mobile periodontally involved tooth? So the main reason to splint a mobile periodontally involved tooth is patient's comfort. I have referred one article actually, and as per that PubMed indexed article published in Dental Update 2007, this periodontal splinting, when used correctly, improves patient comfort, prognosis and outcome for a patient with a serious periodontal disease. So it's mainly done in order to improve the patient comfort, not that the tooth will become sound periodontally, but at least to have that a patient comfort for the time being, right? So the main reason to splint a mobile periodontally involved tooth is patient's comfort. Next, coming to the next point, a patient with a denture cannot make S and TH sounds. The problem is the patient is unable to make S, TH sounds. So the main reason could be excessive vertical overlap, right? So actually we have this elaborate information pertaining to phonetics, right? The phonetic sounds, causes, or the reasons why the patient is unable to pronounce those words, and the solutions. We'll discuss this particular topic in a separate video again, right? Because it's an elaborate one. Come to the next one. Between which teeth is the primate space found in mandible? In case of mandible, primate space is found between primary canine and molar. In case of maxilla, primate space is present between primary lateral and primary canine, right? So these primate spaces, they are also called as simian spaces or anthropoid spaces. They are mainly used for early mesial shift of maxilla during eruption. They are found in about 87% of cases. Come to the final point, high proportional limit gives a material. When we say that a material has a very high proportional limit, it means the material has high resistance to plastic deformation. So proportional limit is nothing but a particular point in a stress strain graft till where the stress is directly proportional to strain. It's nothing but Hooke's law. So beyond that particular point, so within that point the stress is directly proportional to strain. Beyond that particular point called proportional limit, there can be plastic deformation. So higher the proportional limit, the higher the resistance of that particular material to plastic deformation, right? Hope it's clear. So these are some of the important points which I wanted to discuss. So compared to previous video, I made this particular video comparatively more elaborate so that I can give more information in a crisp manner possible, right? So hope it's clear. Thank you.